Hi, Dr. Dominiecki. Welcome to the conference. Thanks for being here. Can you tell us what what your PhD is in and where you work and what you do for work?
Sure. I am a science PhD. My PhD is in basic medical sciences with a specialization in microbiology. But I've actually been working in oncology for most of my career. I work for a company called The Planning Shop. We do healthcare market research. So much of my job is around interviewing physicians, nurses, patients, and caregivers who are dealing with cancer.
But today's talk actually has not too much to do with any of that. You came to our attention because of an article you wrote in the Journal of Oncology by the American Society of Clinical Oncology about how cancer patients sort of keep feelings or descriptions of their pains and miseries to themselves in service towards being like the good boy, the good patient. Can you talk a bit about that, please?
Yes, and I should probably also mention that I'm a cancer survivor myself. I was diagnosed with breast cancer about 4.5 years ago. So I also have the perspective of going through cancer myself. So yes, so through my own observations as well as observations through many different interviews that I've either conducted myself or viewed, it's clear that patients often hold back. There's a lot of messages that go to patients either directly or indirectly that tell them they're fighting this fight and they have to be strong. And it's hard for them to then show that they're actually vulnerable and that this is really hard. So in many cases, they're putting up a front because they're afraid to share their feelings, or they've tried to share their feelings and the other person reacts in such a way that it makes them stop sharing because the other person clearly is negatively impacted by their feelings. So that causes them to then not share them anymore.
Let's start. And that's a very good encapsulation of what we're about to talk about. Let's start with like why this idea of fighting cancer. I mean, do you fight diabetes? Do you fight cardiac issues? Do you fight a broken leg? But much more often than not, fighting. I mean, when did the war start? What's all this about?
That's a great question. I'm honestly not sure where that started. Certainly, back in the day, there was declared a war on cancer, but that was more about trying to come up with treatments. It wasn't really about what the patients are going through and what the patients are doing, but it has been throughout many different arenas through some of the advocacy organizations, through some of the advertising that you're in this battle. And part of the problem with that analogy is that then it seems like the patients lose. And you see it in obituaries too, which is really sad. So and so lost their long battle with cancer. And it sets up this idea that patients simply weren't strong enough, or they didn't fight hard enough, and it's so wrong. It's so wrong. I mean, you can do everything right as a cancer patient and still have things go wrong.
Yeah.
So yeah.
And it's not really specific to men's cancer, is it?
No, but I think in some ways it's harder for men to show their feelings in general, but then also specifically around cancer because they have that added layer of stereotypes where, you know, men are supposed to be strong, men don't have feelings. I'm very involved with a group called Marriage Encounter, and we talk about feelings all the time. And I can't tell you how many men say before they got involved with Marriage Encounter, they didn't think they had feelings. So it's one of those things that's kind of embedded in our culture and in our society, that men are supposed to kind of put a lid on it. They're not supposed to cry. They're not supposed to have feelings. And it's wrong. We're all people, so we obviously have feelings and emotions that go along with everything that happens to us.
Yeah, and you know, it's sort of a 1950s style construct. On the other hand, like, you know, we're a prostate cancer support group network, and we got during this, you know, as we close out 2020, we've got about 76,000 people attending our online communities through 3 different platforms. And those folks are not being quiet, you know, and when we had in-person support groups, those folks were not being quiet. You know, I think, as you say, it's stereotype, but, you know, it's sort of chicken or egg kind of thing. I mean, there's certainly nothing biogenetic about a guy keeping quiet. It's sort of this imposition of a stereotype, and whether or not you buy into it. I mean, as an organization and a patient advocacy organization, we simply say BS on that, you know, which stands for bullshit. You know, the idea of men sort of not keeping, of not sharing what's going on with them in terms of pain and misery as a consequence of cancer treatment, though, there's a different layer around that, isn't there? And can you talk a bit about that?
Yes. I want to first say, though, that having that support community is amazing. And I think every patient needs to find that safe place where they can share. And, you know, it may not be with a family member or a friend. It's great when it can be, but in some cases it can't be. So to have that broader community, to have that group of people who understand what you're going through, that you can really share how you're feeling and how things are impacting your life, I think is incredibly valuable. I think around symptoms and side effects, it's really important that there's a level of comfort in discussing those things with your medical team. So, you know, hopefully that's with your oncologist or your urologist, if, assuming you're still being followed by both. And if not with one of them, certainly with someone on the nursing team. Sometimes things are overlooked, or you downplay things as a patient because the messages that you keep getting are that the most important thing in your life is you're battling cancer, and, you know, yes, there's going to be side effects to the medication, but the most important thing is you're battling cancer. And so there's a tendency to kind of downplay some of the things that you're experiencing and to just think, well, I have to suck this up. But it's really critically important to discuss those things with your medical team, because A, there are things that can be done to potentially minimize those side effects. But B, they could be indications of something bigger and that needs to be addressed. And so if your care team doesn't know what's going on, they can't help you with those items.
So let's get a bit more specific. Like you said, people should feel comfort with their doctor. You know, what does that mean?
It means that you need to be able to share with them what's going on, and
why,
not.
So let me interrupt. Why wouldn't you share?
Why wouldn't you share?
I mean, here's what I'm sort of trying to tease out. The idea that men and women, I mean, it's not a gender-based thing, but the idea that most people want to be the good patient. You know, we all want to be the favorite of everything. you know, whether it's a, you know, I'm the favorite, you know, the favorite of my spouse, you know, I'm the favorite of my children, you know, I'm the favorite of the world, you know. If I go into a restaurant, I want the waiter to like me, you know. I mean, you know, absurd things like that, but I want to be liked 24/7. You know, it's the rare case where it's either irrelevant or objectionable to be liked by somebody. You know, within a doctor-patient relationship, you want to be liked because there's a bit of a transactional issue. You want the good treatment. You want the doctor to really be investigating what's going on with you and what to do about that. I mean, does that make sense? I mean, has that been your experience in interviewing patients and things, that that's what they're going for?
Yes. I mean, I think beyond, I agree with you, what you said, but I think beyond that, you're worried about being labeled as the difficult patient. So, you know, the doctors are making judgments on their patients every day. You know, they're looking at what the patient looks like when they walk in the room. They're listening to what the patients say and what they don't say. And so there's this concern that if you complain too much, or, you know, if you seem like that difficult patient, that maybe you're not going to get the best treatment or the strongest treatment. And so I think there's some concern around sharing things or complaining too much and seeming like that difficult patient, and that potentially impacting what treatments are offered to you.
Yeah, what do you think patients imagine would happen if they're perceived as the difficult patient?
That the physician won't want to treat them, or will want to spend less time with them, or may give them a weaker, milder treatment, one that has less side effects, in hopes that they don't complain as much. So, you know, whether that's real or not, that's certainly a concern of many of the patients.
Yeah. What can people do to sort of get past that?
It's a good question. It's a good question. I think the more you can have that open and honest dialogue with the physician to say, I'm experiencing these things. Do you think it's from the disease? Do you think it's from the medication? What's been your experience with patients who are having these side effects? Will they get better? Will it get worse? How long do I have to endure this particular side effect? And then, you know, beyond that, to, am I okay with dealing with this side effect? So, you know, just being open and honest about what you're experiencing, and also how much that means to you. So, kind of taking away the doctor's interpretation of what you're saying, that just because you've brought it up, it's a big concern to you. Maybe it's not a big concern. Maybe it's a little concern. So, you know, actually putting what you're saying in context for the doctor and the care team, I think is really important. So that they're not thinking that just because you brought something up, it's a big issue. Tell them how big an issue it is. Don't let them figure it out themselves.
Yeah, everything has both a name and a quantity.
Exactly.
Yeah, and a utility as well. I mean, perhaps the patients could also, people, everyone could share not just what's going on for them, but probably the reason that they're bringing it up, which is, right, quite frankly, you want to get better, you know?
Exactly.
You know, and it's not, you could return to the idea of the transactional thing, where it's not just that I want to get better, but I want you to be a good doctor to help me get better. And I'm giving you a bit more information so that you could do better doctoring.
Right.
You know? Yeah. Because everybody wants good patients and everybody wants good doctors. But if you're doing medicine in a vacuum, you know, or in a, what would be a dark room, I guess, or, you know, a place where you don't have a lot of information. Like, everyone choose your metaphor. But, you know, the idea of not giving information is the same as refusing to take a blood test. You know, what's the difference really, you know?
Right.
Do you find that patients actually avoid consultations when they're not, or going to see their doctor when they're in misery or distress, hoping to see their doctor when they're feeling better?
I think that might happen with some patients. They may postpone visits if they're feeling particularly bad one day. I don't know how often that happens, but I do think that happens. I also think they postpone making those phone calls to let the care team know that something's going on, and they wait it out and they try to see, you know, is this going to get better? So I think that there's a lot of delaying, letting the care team know. And as I mentioned before, that can sometimes be dangerous. It can seem like something small to you, and to the care team, it may be a sign or a signal of something that's coming. And so you shouldn't wait if you have a new symptom or something new that's going on.
Yeah. Is this sort of, I mean, and that's based in fear, basically. Is that fair to say? You know, afraid to make a phone call to say something bad's going on.
Yes.
Yeah.
Yes.
Yeah. And not just afraid about the saying something's bad, but again, like, what's the doctor going to think? Am I bugging him too much, or her, you know, too much? You know, this idea of good patient versus bad patient. I mean, you've interviewed doctors in your work doing research and such. I mean, what do doctors say about, do they ever characterize patients in a good or bad way?
I wish I could say they didn't, but they do. And it's not overt. So it's not as if they will come out and consciously say, you know, I have good patients and I have bad patients. But in some of the things that they say, they will characterize some of their patients in that way. And I have to say, it's a minority of the physicians, but it does happen. It does happen where you can clearly hear in what they say that sometimes they're putting blame on the patients, that they're sometimes interpreting things with the patients and they don't think the patients are doing enough or doing the right things. And again, I want to stress, though, that it's a minority of physicians. Most of the oncologists are in this because they really want to help the patients and they really want to understand what's going on with their patients and do the best job that they can. They want to be a hero for their patients. So it's a minority, but it does come up occasionally underneath the hood, so to speak.
And there's no way to figure out whether it's your doctor or not that's talking behind your back, or, you know, labeling that. So, you know, there is some validity for that feeling. I mean, patients are not wacky or insane for thinking, you know, like, I want to be the good patient, or, yeah, I mean, this is because doctors are human, right?
Right, right. And I think it gets reinforced a little bit too, because if you call and you talk to the nursing team, they want to reassure you. So often when you make those calls, they'll say things like, we're really glad you called, but we don't want you to worry because it's probably fine and everything's good. And so they're well-intentioned by, you know, trying to reassure you that whatever you're experiencing is normal and everything's going to be fine. But by doing that, they almost discourage you from raising things because they're in essence telling you it's not a problem. So maybe you didn't need to call in the first place. So it's kind of a fine balance there in terms of, it's great that they're trying to reassure patients, but by the same token, if a patient is experiencing that too often, it may actually discourage them from making those phone calls.
Yeah, and it sort of also, it supports the idea, the BS proposition that men don't talk or patients don't talk, because nurses and nurse practitioners, doctors, whoever's picking up the phone at the other end are not only reinforcing that, they're illustrating it. They're saying, don't talk, because
Right.
they're not talking. They're not engaging the patient on whatever is ailing that patient.
Right.
If a guy calls up and says his catheter is irritating him after a surgical procedure, his urinary catheter, and like the tip of his penis is burning like it's on fire, and he hears from the physician that'll go away, or, or just put some Vaseline or ice on it, and, I'll see you in a week. That's sort of like saying, like, it's, I'm not going to share my feelings. I'm not going to share my concern about it, because
Right.
of course there's concern about it. It's a problem.
Yes.
But yeah. I mean, do you find doctors sort of illustrate the idea of basically not sharing?
I think to a certain extent they do. And the other thing that happens is as patients progress, or when patients progress, some of the doctors start disengaging and spending less time with the patients, or pushing the patients off on other people on the care team. And on the one hand, again, getting back to this idea that doctors are people, you can understand that, they've been caring for this patient for a while, and they have feelings for this patient, and this part of the journey is quite difficult. But on the patient end of things, that can make things even harder and more difficult for the patients. So they need that constant, that constant care team, and they need somebody that they can rely on and be able to have those frank conversations about what's happening.
Yeah, and everyone's a person, ultimately.
Yeah.
I mean, we're not dealing with your dog, which, is, well, thank you to Sandy for joining us today, but we're not dealing with, abstract, creatures or fictional characters, which is to say, there's not a hell of a lot we can do to get over this idea that our internal emotional life and our concerns about wanting to be excellent, wanting to be cared about, wanting to be cared for, and wanting to be prescribed the correct, useful treatments that won't hurt. All of those things, are just sort of part of who we are, and, they're countered by, like, this, I've worked with this patient for so long and now they're near death. I can't be near that, let me, a resident should, or, just, I don't know what to do, so maybe someone else could be referred, the person could be referred to someone else. It's a horrible quandary for everybody to be in, and there isn't any. I mean, I think you spoke before that there really isn't a clear solution or on the emotional pathways around this, right?
No, but I think the more dialogue around it, the better. So, as patients, we can raise things, as I mentioned, to our care team, and we can ask those questions around, how normal is this? How long do you think it's going to last? Are there things I can be doing outside of treatment that can help mitigate whatever it is that I'm experiencing. I mean, there's a lot of alternative things that you can do alongside with your treatments. There are nutritional things, there is acupuncture, there is exercise. There's a lot of different things that you can do to help with some of the things that go along with cancer and its treatments. So I think it's important to ask those questions. But for the care team, I think it's important for them to ask questions as well. I mean, so I think they need to show some empathy for what the patient is going through. I can't tell you how comforting it is when you have your doctor say to you, I don't actually know what you're going through because I haven't been through it myself. That's a huge acknowledgement to have a doctor say that to you and to have them show genuine interest in what's going on with you and how it feels. And so I think the care team can do a massive job in showing a bit of empathy, in asking the right questions to draw that out of the patient. And that can just elevate the care and make it that much better.
Yeah, I think a thing that it's wrong for patients to be encumbered with, you have to do things, you have to advocate for yourself, you have to like do X, Y, or Z. I mean, you got a disease, you want somebody to fix it, and you want that to be the end of it. Unfortunately, that's not where we are in 2020, 2021, and certainly not in the lesser developed world. We're not anywhere near that in the developed world, in the States and Europe and Asia. We're just not there yet. But it would be good for patients to sort of tell doctors, from the get-go, this is how I'd like us to communicate. And I'm wondering how it would be good for you to communicate with me. I want you, for patients to say, look, I want you to ask me questions. I may not know what's important for you to know. So, I know you're trained to do that. I know you're going to do that, but I want you to be clear that I'm comfortable with you doing that. If, I talk about the most intimate things, touch me wherever it's useful for you to touch me, and for patients who don't feel comfortable with that, to share that as well. Like, I really don't feel comfortable with you, touching me around the anus or something, or feeling my lymph nodes, or something like that. Or I don't want to know anything. You just tell me what to do, I'll do it, and that's our relationship. But clarity of purpose on both ends is essential. And unfortunately, it falls to the patient to actually speak up about that, to enunciate that. And fortunately, most patients, if not all patients, are capable of doing that, either verbally or just writing it down and sort of in school, handing a note to somebody, just passing a note to the doctor. This is how I want us to talk. I'd like your cell phone number. If you don't feel comfortable with that, I want an SMS or email. But I can only feel comfortable with direct contact with you. Mm. And if the doctor doesn't feel comfortable with that, then there's no comfort,
Yeah, I think that's a really great point. And the other place I see that play out is, the doctors are, again, making interpretations based on the questions that are asked, the questions that aren't asked. And so the level of information that they're sharing is based on their interpretation of what the patient wants to know. And so if the patient can be clear about what they want to know, I think that's really helpful. And sometimes, the patient only wants a certain amount of information, but their caregiver wants more information. That's important too, that the doctor and the care team know that they need to separate them and give the patient a certain amount of information and give their caregiver a different amount of information. I always joke that I'm convinced there's a note in my chart that says she goes to ASCO every year. She knows stuff because I ask questions like, well, what's the scientific study that shows that this is the right treatment path that we should be on? And, you know, where's the data that shows we should do this and not that? And, you know, those are the kinds of questions that I ask along the way. And I'm atypical, I think, of many patients because I do want to dig in and see that scientific study. And then, you know, I ask questions and I come up with odd things that other patients don't come up with. Just as an example, my breast cancer was stage 2B, which means it was in my lymph nodes. So I will never get an all clear that it's totally gone because it was in my lymph nodes. So there's no way to know. And what I didn't know, even with all my work in breast cancer, is that they don't do follow-up scans if you're in that situation. They just scan you when you have a symptom. And at one point, one of the doctors on my care team, I think it was the breast surgeon, said to me, yeah, well, they've shown that it doesn't matter whether you catch it on a regular scan or if you catch it on a scan following a symptom. And I said, yeah, both are equally bad. You're then stage 4 metastatic disease and you're going to die of your disease. And she looked at me and said, you got that from what I said? I said, yeah, what you said and what you didn't say. You know, and so I think doctors need to know who they're dealing with and the level of information that they need and want, and you know, how they're going to interpret the things that you say and the things that you don't say as a physician.
Dr. Dominiecki, thank you very much for this helpful conversation. Thank you for the research that you're doing and helping to advance our knowledge base so we could fix things better and faster and with less pain and misery. And welcome to the conference. Thank you.